Hello, my name is Dr. Beatrice Melley. I am the principal investigator AMPATH Multiple Myeloma Program, and I work in Moi Teaching and Referral Hospital in Kenya. My experience in taking care of multiple myeloma patients over the past decade in our hospital are patients coming in with difficult pathways towards the process of diagnosis. Some of them have been in the renal unit, some have been in the orthopedics clinics or physiotherapy units for months and months before they are able to reach us for us to be able to confirm the diagnosis. And therefore you find that these patients reach us when more than 75% of them have a advanced multiple myeloma. So in Kenya, quite a number of these patients present late. Some come in with severe anemia, some with fractures, and some with renal failure. And mainly this is because of limited access to diagnostics and also limited expertise, or rather an expert team that has an high index of suspicion that this could be multiple myeloma. But that is not the biggest challenge. Our biggest challenge actually comes after diagnosis. And why is it so? Because we are able to give them the first line treatment of multiple myeloma. However, access to second-line therapies is still a huge challenge. We do not have the second-line, third-line, or fourth-line therapies. We don't have access to bone marrow transplant. We do not have monoclonal antibodies. We don't have the CAR-T therapy. And therefore, this leads to challenges in being able to manage these patients. So apart from that, many of these patients actually live far from the hospital, and therefore doing infusion therapies is not something that is feasible, and too often we find ourselves having nothing to offer to our patients who have relapsed. We are going to conduct a phase 1 clinical trial involving use of clofazimine and dexamethasone for patients with relapsed multiple myeloma who currently have no options. This clinical trial is actually practical in our setting because one, it's an oral drug, and therefore for patients who are coming from far, this is something that they can be able to use quite easily. It's also low cost and therefore affordable, and we are going to conduct these clinical trials through the systems that we have, or rather networks that we have established through AMPATH and through also the Moi University Clinical Trials Research Center. If effective, this clinical trial can be scaled up to not just the East African community, but also to Sub-Saharan Africa, which I believe are also facing the same challenge that we are facing in Kenya. We are also building a community engagement process. Recently, we launched what we call the Multiple Myeloma Association of Kenya, and this is hopefully going to be able to produce clients or more clients for clinical trial participation. This project is about equity. It is about patients who have relapsed and currently have no options, and we are going to turn an existing accessible drug, which is clofazimine, and scale this to a possible solution for patients who have relapsed multiple myeloma and currently have no option. Thank you.
Thank you, Dr. Beatrice. My name is Attaya Suvannasankha. I am a myeloma physician and a professor of clinical medicine at the Indiana University Cancer Center in Indianapolis, Indiana. I have been working with Dr. Beatrice for the past 4 years under our collaboration through the IU AMPATH program. AMPATH program has been around for 30 years, started with AIDS research and now expanding to cancer research. Our collaboration intends to make treatment accessible to patients in the region. To bridge this critical need, we are proposing repurposing clofazimine, an oral agent available in the region for the treatment of tuberculosis and leprosy, for the treatment of relapsed multiple myeloma. This proposal stems from a rationale finding from our lab, we showed that multiple myeloma cells have an activated pathway called aryl hydrocarbon receptor pathway, which is blocked by clofazimine. This pathway allows the cancer cells to grow, metastasize, as well as resisting therapy. When we test this agent in the lab, clofazimine inhibits the tumor growth both in the test tube and also in animals. In addition to that, it actually works well in combination with other myeloma treatments. It may also work not only by killing the tumor cells directly, but boost up the immune response. So now we're repurposing agent that we have already known how to use it in the region and to move it to offer a low-cost, accessible option in relapsed myeloma. This clinical trial will primarily be done in Kenya, and additional information both from the side effect profile and also the efficacy will be captured. In addition, we will collect some blood and bone marrow samples for us to be able to further analyze them using my infrastructure at Indiana University in the US, so we can not only know whether the drug can work and at what dose, but also what kind of biomarkers would inform future drug development. If this would be successful, the treatment can be expanded to broader region in Kenya and sub-Saharan Africa, as well as it may also inform further drug development in the US and Europe, particularly by targeting this pathway in addition in conjunction with novel therapies, including immune therapy. I hope that you find our proposal interesting and appealing for the funding. Next, you will see the video about our facility in Kenya.